on the occasion of launch of Pediatric Nephrology and Pediatric Critical Care Unit at Mahatma Gandhi Medical College and Hospital. I feel proud and extremely overwhelmed to be part of this esteemed institute. On behalf of MGUMST, I cordially welcome all the distinguished and renowned pediatricians and senior faculty for this event. We are blessed to have very popular and prominent national faculties with us today. Our first speaker for today is Senior Consultant in Gangaram Hospital, Pediatric Neurologist, Dr. Praveen Kumar sir. Dr. Praveen sir is working in Gangaram Hospital as a Senior Consultant Pediatric Neurologist. Dr. Kumar has more than 40 publications in national and international journals. Dr. Praveen sir's area of interests are refractory epilepsy, stroke, chronic headache, and pediatric syncope. Refractory status epilepticus is a neurological emergency with considerable mortality and morbidity. To enlighten us with the current knowledge of its management and importantly role of video EEG in pediatric ICUs, I would like to invite our first speaker for this evening, Dr. Praveen Kumar sir. Sir, please.
So, a very good evening to all of you. And at the outset, I would like to thank the scientific committee of Mahatma Gandhi Institute for inviting me here, and especially to my dear colleague Dr. Roop. And congratulations to for starting the new pediatric nephrology and pediatric critical care unit, and all the best wishes for that. So it's my honor to be present here. And today the topic which had been given to me is about pediatric status epilepticus and refractory status epilepticus along with the video EEG. So I would like to, we all know about the different steps, the different approaches which we need to manage cases with the pediatric status. I would like to share some of the clinical things which we come across in our day-to-day pediatric intensive care practice on our. So look at this case. This case came to us a couple of years back. He was a young child who had history of fever for 2 days, almost 7 days back. Then he had an episode of seizure at school. He was shown to the nearby practitioner. His MRI brain, EEG brain was found to be normal, and he was put on sodium valproate because he had seizures post resolution of the febrile illness. Subsequently, his irritability had increased, so they increased the dose of sodium valproate. By the time he came to me, the parents felt that he was irritable because he was at the nanny's place, and now he had been brought to his home, mother's place. But when he was in front of me in my OPD, what he had that I was checking the history, and subsequently he had this episode. So look at the way. So he is still staring and he is drooling. What we used to previously called as complex partial seizure, now we regard them as a focal non-motor seizure. So he had this episode in front of me only. This was a kind of like focal seizures what he was having. We admitted him in the pediatric ICU and gave him the further medications, levetiracetam. He didn't have any other focal deficits. Seizures subsided. His other examination was normal. One point which is important, which I would like to highlight over here is this: a child who gets seizure after a febrile illness which has already subsided, it is very likely that he will have repetitive seizures. So a child who gets seizure during the fever is one thing. A child who gets seizure when the fever has occurred and it has subsided, it is very highly unlikely that this will stop with only one episode of seizure. This is more chances of that this will have a kind of like repetitive seizures. We admitted him. Subsequently, he became quite restless. He had poor eye contact and he developed repetitive orolingual brachial movements. Look at the way he is having basically. So a child who is becoming losing his sensorium, going into the altered sensorium, and then starts having these kinds of abnormal movements. You always think about, are they really a part of seizures? Are they part of non-convulsive episodes, or are they kind of like non-epileptic episodes? We got the video EEG in this case, and that was one of the subtopic of today's presentation also. So we got the video EEG and we found that this was a non-epileptic event. So these have to be correlated with our EEG and video EEG to make sure this is not a seizure which is going on. But at the same time, he had frequent convulsive seizures also, and he was given subsequently further medications, and he was put on midazolam infusion and he was ventilated. We got his basic labs done. They all were unremarkable. The EEG has delta brushes. You can see over here. This one. This is delta waves, and you can see brush over the waves. So this is like a brush over the waves. Delta brushes, which are not very pathognomic, but they are seen in cases of autoimmune encephalitis in these parts. He continued to have repetitive seizures. He was subsequently loaded with the ketamine. And then ketamine infusion was given. He continued to have seizures. We put him on thiopentol infusion, and subsequently we put him on the ketogenic diet also on that sort. Because his MRI brain was normal and he was still irritable in altered sensorium, we got the PET scan done, and PET was abnormal, which was showing hypometabolic area in the posterior part of the brain. So that is also again a feature of autoimmune encephalitis. And then we loaded him with the methylprednisolone and subsequently with the IVIG, and we put him on the ACTH on the continued management plan. After a couple of days, his CSF, autoimmune antibody came positive for NMDA receptor, this one. And once his antibody came positive and he was still having those alteration in sensorium and the behavior, we went for the plasmapheresis, and we gave him almost 6 cycles of plasmapheresis after the part. And definitely subsequently he was much better. If you look at him, he was interacting with the mother also. He was having a good eye contact, and subsequently he was put on the oral steroids and we discharged him. This is after a couple of weeks he came back to us in the OPD part. So this was one of the cases we had couple of years back, and we published this case also because of couple of reasons. This was one of the cases earlier where we had the normal MRI and we had an abnormal PET scan to suggest and to strengthen us to go for further immunomodulatory management. And that also tells you that sometimes when you have got a normal MRI in a child who has got encephalitis, encephalopathic presentation, you can go for the PET scan to substantiate your thoughts about him having the encephalitis like phenomena. Because parents becomes practically it becomes difficult to counsel parents to go for plasmapheresis if you're not finding anything in the CSF or anything in the blood to cause to tell them about the possible etiology. Because they keep on asking that when the MRI brain is normal, when the CSF is not showing any organism, why my child is having so many repetitive and refractory seizures. So we have found, thereafter we have a couple of more patients with the PET scan, and we found at least this modality has helped us in counseling the parents also and strengthening our part also that something is going abnormal in the brain part. So this tells you that whenever you have got a successful patient of these kinds of refractory repetitive seizures, the most important part is a very good core pediatric ICU team, which I have realized in past more than almost 12-15 years of my pediatric neurology practice, that these patients can't come up out of the ICU if you don't have very good pediatric ICU team basically. Because what they need the most is a daily ongoing care so that they can sustain their own initial insult from the etiology. They can sustain the insult of all those medications which are being used to control their ongoing seizures, and that is the most important thing which really prevents them from their mortality in those cases. So we all know seizures are most common in pediatric age group, and the same is true with the status also. The most commonly we find a status coming in the age of less than 5 years, and febrile status epilepticus is the most common etiology for status epilepticus in these cases. The practical definition, we understand that any child who comes to us seizing in the office is in status epilepticus, and you have to start managing him as the case of status epilepticus. If the seizure continues despite him receiving two medications, the benzodiazepines and the first line anticonvulsant like phenytoin, sodium valproate or phenobarb, he goes into the refractory status part. So you have given two drugs, the benzodiazepines and the first line phenytoin or valproate or levetiracetam. If he still sees, it becomes a refractory case, and once you have put him on the coma induction medications like Midas or those ones, and he is still seizing, that becomes a super refractory status. Sometimes you can have the subtle status also, where you find that children have stopped having the generalized tonic-clonic seizures, but they still have a small motor twitches and facial twitches. So that also needs to be addressed, that also needs to be managed, because they are equally harmful for the brain, and that again requires your a good quality video EEG to correlate in these cases. It can be convulsive and non-convulsive. For non-convulsive, we need to have a good video EEG correlation, so that we don't miss the ongoing electrical seizures. In fact, you will find that almost in the first 24 hours of convulsive seizure, if you don't manage them or monitor them on the EEG, almost more than 20% cases can be missed, because they can only have the electrical seizures after the convulsive status. That's why the video EEG becomes very, very important, especially in the first 24 hours of the convulsive status epilepticus in those ones. See, the basic concept about status is still that time is brain. So they find that if you start managing them at home, out of the hospital, chances of you managing the status and refractory status is much easier, because the delay in giving the first dose of benzodiazepine results in making the seizure much more refractory to the medications and causing much damage to the brain and to the further neuronal network. So the message is to teach the parents about the first line domiciliary management of the seizures at home if a child has got past history of seizure or epilepsy on that part. When you talk about the etiology, like when a child comes to us with the seizures, this is the etiological classification from the ILE, which had come couple of years back, and I find it very useful practically. Whenever a child comes to us with a seizure, be it a status or refractory, the cause lies somewhere in these 5 or 6 categories only basically. Either it can be a structure because of like HIE or NCC or tuberculosis in the past, it can be infectious like what we heard in autoimmune encephalitis, or like post-infectious, it can be in a metabolic conditions. We have got a lot of channelopathies and those ones which can give rise to or conditions, or it can be immune like fires and those ones, or it can be genetic etiologies. So whenever a child comes to you, you have to think about whether this is an infectious, you require the LP for that, post-infectious, you require the autoimmune antibodies for that, this is a structural, you get to know about the MRI brain or the PET scan in those cases, and if not, then you go for the immune mediated and you treat them with the immune modulatory medications. And as I said to you earlier, the most common cause for status in children is febrile status epilepticus, the kind of thing. So yeah, sorry. So what causes a seizure to become refractory? So definitely the thing which is modifiable is initiation of the first drug, the benzodiazepines. If it gets delayed, there are different literatures which say that it becomes much more difficult to treat them after once you have missed the bus for the first 5 minutes or 10 minutes of the seizure onset. The second is definitely if the drug has not been given in a good dose, especially like if you are given the half loading dose of phenobarb or half loading of the phenytoin, fearing about the respiratory issues and those ones, they become refractory. And third is definitely etiology. Like as I mentioned to you in the beginning only, once a child has got something which is when the fever has subsided and then he starts having seizure, you make it known to you that this is very hard to stop by only 1 or 2 episodes of seizure, because they are more likely to go into the fires and autoimmune kind of thing. So etiology will also make it refractory in those cases. So, but etiology you can't control. What you can control is basically your initiation of the medications as early as possible and giving the medicines in the correct loading dosage which you can manage yourself. What happens that whenever the seizure, we have got only two systems, like the inhibitory system, which is GABA in the brain, and the excitatory, which is glutamate or NMDA in the brain. So when the seizure starts occurring, you have got more amount of GABA in the brain and less amount of glutamate or NMDA in the postsynaptic neuron. These are the GABAs, the blue ones, while the NMDA, which is excitatory, is the red ones. GABA is inhibitory. So when the seizure starts, you have got more amount of inhibitory neurotransmitter as compared to the excitatory neurotransmitters. But what happens when the seizure gets prolonged? You get the internalization or receptor trafficking of the GABAs. So GABA becomes internalized, GABA goes inside, and you got lot of amount of the NMDA or excited neurotransmitters in the postsynaptic neurons part. So it means that when the seizure becomes prolonged, it becomes automatic also. Automatic means the inhibitory neurotransmitters in the brain has got internalized and you get more amount of excited neurotransmitters. It becomes difficult to control when the seizure becomes prolonged, and you don't get the medicines which normally act through the GABA, like benzodiazepines, because they act through the GABAs. So after a couple of minutes, they won't be as effective because the GABA has lost its potentials from the receptors. It's not there in the case. That is the thing to know. When we talk about the management of the status, there are three things which we need to know. We need to have the control of seizures. We need to control the underlying etiologies also, like if it is sepsis, meningitis or encephalitis, you need to give the medications like acyclovir for the encephalitis and those ones. And we have to manage at the same time any systemic complications because of the seizures or because of the medications. And here comes the role of having a very robust pediatric ICU team, which includes the doctors and the intensive care nurses and everything over there. The investigations are all patient dependent. Definitely you would go for the basic investigations, basic labs, and go for the CSF and neuroimaging part, but you all know about the part. The investigations, the management and the evaluation, they go hand in hand when you manage a child with the refractory status in this part. Now, the benzodiazepines are the first line of management, and the treatment starts from the home itself. If the child has got already known epilepsy history, we can give 2 doses in a gap of 5 minutes time. Before you give the second dose, you must make sure the child has not received any extra dose at home, because once you go for the third dose, chances of him having respiratory depression is very, very high. And we always make sure that when we ask parents about the midazolam spray, we must make them to have the strength also, because practically we understand that there are two kinds of midazolam, and we have got couple of cases where children have gone into the cardiorespiratory arrest because parents have given the midazolam which has got 1.25 milligram as an 0.5 milligram dose. So it's very practical that we must make sure that they use the correct strength of midazolam strength, because practically it can be quite destroying. So we have midazolam, we have lorazepam. If you have got that has got slightly longer duration of action and most preferred drug in cases of emergency to control the acute episode of seizure. And the second dose you have given on the part. Once you have given the 2 doses of midazolam, either he has received 1 at home or 1 or 2 at the in the emergency, then you have to go for the second line agent if he still continues. Most of the cases who require 2 doses of midazolam or lorazepam, they won't stop. So you need to load them with certain medications. Either it has to be phosphenitrine, levetiracetam, sodium valproate, or phenobarbital, depending upon your choice and ability. But remember, the child who has required 2 doses, it's very unlikely that he will not require the loading dose of medications. Why is to load them with the medications? There can be certain clues. Like if a child was already on sodium valproate and he has missed some dose, you can load him with sodium valproate. A child is already a known case of leukemia, and you have to load him with the medication. He's come with the seizures to you. You need to load him with the levetiracetam because that has got less interaction with the his chemotherapeutic medications. If a child is infant, 6 months, 7 months, 8 months of age, we still prefer loading with the phenobarb, because that's a wonderful drug in children less than 1 year of the age in those cases. If a child has got a history of febrile seizure, and now he is coming with the afebrile seizures, sodium valproate can be a good drug because they have got more chances of having the genetic epilepsies. So I think if you got some clues about his previous history, you can choose among all these 4 drugs which you have to use as a drug after the first midazolam or second midazolam medication on the part. Once you have given the two drugs, I mean the benzodiazepines and the second line agent, either you go for the coma induction by starting with midazolam coma if you have got the ventilatory facility, because that is the ideal thing. But most of these cases who have required now two doses of benzos and one dose of your second line agent, they won't stop. So almost more than 70% they will be still convulsing despite giving the third line agent if you choose to give the other medications. But at times you don't have the ventilatory facility or the parents are not ready, you have to buy time, then you can think of giving the other drug. Like once you've given the phosphentine, you can choose other drug like valproate or levetiracetam, but choose drug which has got something different mechanism of action as compared to what you have already given in the scenarios. But the ideal is to go for coma induction once you have given already two doses of midazolam and one dose of other agent in the part. Once you go for coma induction, you require the EEGs, because you have to monitor both clinical seizures, electrical seizures, and you have to monitor the response to your coma induction agents also. Normally, we use midazolam, which we can start with 0.15 microgram milligram per kg, followed by infusion of 1 to 24 microgram per kg per minute. The thing to remember is this: whenever you increase the infusion rate every 15 minutes, you have to extra load him, because only increasing diffusion rate will not serve the purpose. You have to load again with 0.15 milligram per kg and then increase the infusion by double the rate, or by 2 microgram per kg per minute. A lot of these kids, when they still continues after going the highest possible dose of midazolam like 24 or 30, you can go to the other line agents like ketamine, which you prefer more, loading by 5 milligram per kg and then giving a maintenance of 1 to 5 milligram per kg per hour. Ketamine is an old drug, but this is very effective. We find it very useful in the ICU settings because of its very good hemodynamic properties. It doesn't cause more of a hypotension which all of these other medications causes, like midazolam, thiopentol, propofol. This is a wonderful drug in these scenarios, and we prefer more ketamine as compared to any other drug in this case. In fact, we have used couple of our patients ketamine when we have discharged him on the oral ketamine also. The same injection you can give it orally also for a couple of days on the parts. So if the child continues to have seizures, you can go on the thiopentol. The effect is about the hypotension, and a lot of sepsis with the thiopentol. So we are slightly not very comfortable with thiopentol as compared to the midazolam. Propofol, a lot of our anesthesia colleagues, they prefer propofol because they keep on using it in their day-to-day practice. We in the pediatric ICU, definitely because of its very significant, serious, fatal reaction of propofol infusion syndrome, we keep it slightly lower down the order. But practically, if you ask me, this is much better as compared to all these previous two medications in controlling the seizures abruptly. I mean, you give it and you get the seizures control both clinically and electrically, but you have to take it out after 24 to 48 hours because you can't give it for a long time, while ketamine you can give it for a slightly longer duration as compared to the propofol on the part. Other therapies we keep on adding because we are giving these coma induction medications. Ultimately, you have to take it out. You can't give it for a couple of days more. So you have to build your base also. You have to build your strength also, and that you can build by adding medications like topiramate, lacosamide. Nowadays, perampanel has also come up. We are using it in those parts. Or these ones you can use. You can go for the ketogenic diet. You can use for the the other therapy which is not as practically useful in our kinds of setup like surgery and vagal stimulation, but if it is the diet and other things can be used while you are using the coma induction medications on the part. This was one of the cases which was one of the first from the India. I think Dr. Rupa also was involved somewhere in during the case. This case had convulsions till almost around 57-58 days when we decided that we should go for the electroconvulsive therapy. It was somewhere from the Gwalior only, and we gave him ECT. The first was at around his 57 days of our ICU admission, and then we gave him almost around 2 weeks of regular ECTs. We had already failed all the previous things which we have discussed, and that was the repetitive, including the inhalational anesthesias also. Twice we had given in this case, and that all had failed. And then ultimately we went for the electroconvulsive therapy, one of the first in pediatric age group in India, basically reported on the part, and he responded beautifully to this ECT. He is still under our follow-up, and this is almost around 1.5 years, I think close to 2 years now, and he is doing perfectly fine on that case. We did use ECT in a couple of, I think 2 more cases, but we didn't find so much, good results as we found in this case. So this is one of the things which we can use. We had the psychiatry and the pediatric ICU team with us, and we published also this case. The last year only, as in the Journal of Pediatric Epilepsy. So when do you start weaning these ones? Definitely once you are seizure free for more than 48 hours, you start weaning the medications. And if they start seizing again on weaning, you have to put him back on the medication. The struggle starts. A lot of times, basically, it is more of about the parents' patience. So we always tell them that this will not become happy when he is seizure free for 2 days, 3 days, because the real scenario will come when we start wearing down the medications, because then they start showing their true nature, because they start seizing again, and this can go on for weeks together in the part. So the second part was about the non-convulsive. A lot of these kids can still continue to have seizures if in the non-motoric way. So they have stopped their motoric seizure, but they still continue to have the non-motoric seizures, and for that you need to have a good quality video EEG, which is the part. Non-convulsive seizures, they are not very commonly reported in the pediatric, but most often you find that, as I told in the beginning, that almost 20% of the convulsive status may have electrical seizures in the first 24 hours, and for them you need to have a video EEG or EEG in your ICU settings, because then only you can pick them. And you need them more if you got some child who has got reset convulsive seizures and he is still in the altered sensorium, if he has got refractory convulsive seizures requiring more medications in those cases, if he has encephalopathic, sensorium is not good, and if you are finding some plates on the initial EEG, they need to be monitored with the continuous EEG. Or if a child has been pharmacologically paralyzed, they also cannot show the motoric seizures, you need to monitor them on that sort. Look at this child, this is our pediatric ICU. So this child, the monitor is showing normal, it's normal heart rate, normal BPs. The child is comfortable on the vent, he doesn't have any movements in the limbs, all the 4 limbs are perfectly well placed, totally sedated, and look at the EEG, and he is seizing basically. So you won't find any evidence of seizure either on your monitor with the heart rate and BP or in the motoric part, until you have a video EEG with you when you can pick up, and because they do equally harm as compared to our motoric seizures. So that is why the role of video EEG comes here, because you have to pick them, and they also need you also need video EEGs to pick the other conditions like the seizure mimics which you can have in the ICU. In these conditions only, sometimes they can have the movement disorder, like this child also had a case of autoimmune encephalitis only, and he used to have this kind of abnormal movements. It becomes difficult to say this is not a seizure or this is only a non-epileptic phenomenon until you do a video EEG at this time and you demonstrate that this is only a movement disorder. You don't need to increase the medications in these cases. This was an interesting case. He came to me somewhere from the Kashmir, and look at the way I just made here this still photograph in my OPD only, and this he used to do a number of times in a day. So he used to go into this kind of posting, and this kind of scare anyone in your in the practice, but somehow it made sense that it was not a kind of like true seizures. So what we did, that we put him on the video EEG part. This he is doing in the OPD. Eyes going up, and he is having all the positioning of upper limbs and lower limbs. He must have seen some very good movies. I think he really scared me also in the OPD. And look at the face he is doing. But children being children, they always leave a trail. So like this also, when I saw him in the OPD, when the moment he finished, he was perfectly fine. He was much. He didn't look exhausted. So normally with such kind of seizures, you become exhausted. So you start doubting this is a really seizure or this is not like a seizure, and don't get pathology in the part. So we put him on the video EEG, and I was trying to provoke him that this will come. The EEG is running in the background, this one, and then he starts doing in the video EEG room itself. So he goes into that kind of posture, and we don't find any significant discharges on the EEG in the background which was running. So this was useful for the parents also to understand that what he is doing is not a true seizure. This is a non-epileptic event. So that really gives us information that what is the real benefit of having the video EEG. Definitely in the pediatric ICU setting we need it, especially if you are managing a case with refractory status, because the moment you put him on co-induction medications, you have to start the EEG monitoring also to titrate your medications, when to wean down, when to step up the medications, either you go for the burst suppression pattern or one electrical seizure control. This all will be happening. Monitoring treatment for non-convulsive, as we just saw in such cases, and prognosis also. Like, I mean, if you see a child with the EEG showing plates in the beginning only, so you know this is not a good kind of like EEG. If a child is showing multifocal discharges, it's not a good EEG. If a child is showing multifocal discharges, he may have got a good prognosis in those cases. So they all help a lot when we start looking deeper into these kinds of EEG graph on the part. So prognosis, refractory status is not a good thing. Status is still okay, but once you go into refractory, this is not a good thing. All over the world, you'll find they've got almost 1/3 of mortalities, and they are mostly because they live in the ICU for many days and they get into systemic complications. And that's why in the beginning only I mentioned to you that the success of the refractory status depends upon your core pediatric ICU team, because they go mostly not because of the etiology, mostly they go because of their systemic complications which they develop during their hospitalization for more than 4 weeks, 5 weeks, 6 weeks in the pediatric ICU. We had slightly a better outcome at Gangaram. Past 2 years we had more than 32 cases and we had almost 4 expiry of them, and most often if you want me to recollect, they mostly expired because they had some sepsis and most of them were on the thiopentol, and they go into the cardiomyopathy and the cardiac decompensation basically. So that was the thing which if I look back and I find that those cases they could not be managed, especially once they start decompensating, when they're on the very good dosage of these combination medications, that becomes difficult for them to get revived at during that time. So, I mean, the one more thing. So, the important thing which I wanted to highlight over here: do not try to stop each and every seizure, because then you may land up with the kind of like fatality basically in these cases. So, you remember that these cases which are having super refractory status, even if they come out of the kind of like your ICU, they still continue to have some amount of seizure here and there. Like this child which I showed you on the ECT, he still comes to me in the follow-up, and he's still having some seizure, but maybe like once in 6 months or once in a year kind of seizure. So once you start controlling each and every seizure, then becomes a kind of like different ballgame. So you have to accept that they might have 1 or 2 episode seizures. You have to balance your medications along with some amount of seizure, allowing to have some amount of seizures in those cases. And this is again the same thing that if you delay your benzodiazepines for more than 10 minutes time, it becomes difficult to control the status. So first and the foremost is that you must train the parents about giving them the benzodiazepines at home to make sure that they don't land up in the refractory status in those cases. So to conclude, out of hospital management, we all discuss with our parents, with our children about how to use those medications. Treat early, give the full dose. Don't give the half doses of medications. It's wise to give the full. And in fact, if you talk about the status, there is no higher limit for the medications. If you got the ventilator facility, you can manage the ventilation. You can go to any dose of medications in those cases. Identify early cases which require which can be refractory. And as I mentioned to you, time and again, the children who are having seizures after the fever has subsided, they can be refractory. So don't keep them in the ward. They will require the ICU management most of the times in those cases. Centers with the ventilator and AJ facilities, and most of these young, young children, compared to the adults. So, we talk about the plasticity of the brain. So, these cases which we have seen in past more than 10, 12 years, they even in living in the ICU for more than 2 months, sieging, after a couple of months, they are still doing good. So, like in the young brain, you can still be hopeful. After maybe discharging after 2 months or 3 months of the ICU care also, when they're coming back, they have got some cognitive element, they've got some here and there seizures, but they manage to have their normal ADL independent life on the part. So still you can hopeful in case you are managing your young children with the refractory epilepsy on the part. So thank you very much. Thanks.
It's always a pleasure to hear Dr. Praveen sir. He's one of my mentors from Gangaram Hospital. We'll take question answers after both of the presentations. Now I would ask Dr. Ramesh to greet Dr. Praveen Kumar sir. Moving forward, I would like to welcome our honorable chief guest of the evening to make this event more memorable. Dr. Vikas Swarnkar sir is honorable chairperson cum chancellor of Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. It's a well-known proverb that actions speak louder than the words. With the visionaries like Dr. Vikas sir, this proverb seems to do justice. Sir, you inspire us every day with your insight and work. I would like to ask and request Dr. Munish Kakkar sir, Professor and Head Department of Pediatrics in Mahatma Gandhi Medical College, to greet Dr. Vikas Swarnkar sir. Moving on to our second presentation, our second speaker for the evening is Dr. Amit Agrawal. Dr. Agrawal is in charge of Pediatric Nephrology Division in Rainbow Hospital, New Delhi. Dr. Amit Agrawal's area of interests are difficult nephrotic syndrome and pediatric urinary bladder dysfunctions. He has a vast experience of doing more than 15,000 pediatric dialysis that includes hemodialysis, SLED, and CRRTs. And going on to his topic, the topic for this evening will be acute kidney injury in pediatric population, recent advances and challenges. Dr. Amit sir.
Hi, first of all, I would like to thank you, Dr. Yashu, whole management and team of Mahatma Gandhi Medical University, and congratulate them on the launch of exclusively pediatric dialysis center and a very good pediatric critical care unit. All the subspecialties in pediatrics depends on the intensive care, whether it's a cardiology, neurology, nephrology. They just can't survive. So our survival basically depends on the intensivists. So the good intensivist can save many more lives than any of us can do. So it's basically a collective effort, and we all just can't do without the intensivists. They are the backbone of any pediatric center, and I am very happy to have Hi, thank you. So I would be talking on a acute kidney injury. Basically, acute kidney injury been there, uh, has been developed over the last 15 years. This term was non-existent before 2005, when the rifle criteria came in 2004. So then the acute kidney injury we understood beyond acute renal failure. Earlier, the only known thing was acute renal failure, when the kidneys actually shut down, and the injury is they are getting harmed. So if we look at the definition of acute kidney injury right now here is, so this term is obsolete now. There's no more acute renal failure. So it is characterized by the abrupt deterioration in kidneys over days that disrupts metabolic, electrolyte and homeostatic functions of a body. Thank you. So we call it acute kidney injury. There is no more acute renal failure. Not moving. Slide not moving. Or two. So initially in 2004, the rifle criteria came, then the pediatric rifle, then we have a acute kidney injury network. The major breakthrough came in 2012 when the KDIGO proposed the uniform guidelines for both pediatrics and adults about acute kidney injuries. Then we started to standardize, finding out the incidences and the prevalences across the various age groups, across the various subgroups in whether it's a outpatient, inpatient, community born, intensive care, all those kind of things. In 2013, the neonatal rifle criteria was proposed, but it has still not been standardized. So initially, the rifle and akin helped us to find the incidences, and then we started to know how does the acute kidney injury, not the failure, affects the outcome. And as we move into the 2022, we understand whether is AKI actually leads to CKD, or does each AKI leads to CKD, or there are some special forms of it which leads to CKD. So this is the KDIGO guidelines. The KDIGO guidelines are pretty simple. If you have a serum creatinine which goes beyond 0.3, so if somebody is having a serum creatinine of 0.6 and it has gone to 0.9, it's a stage 1 acute kidney injury, or it has been doubled. So if somebody has a 0.3 and this has become 0.6, then it means acute kidney injury, or the urine output of less than 0.5 ml per kg per hour. Even this small changes has a long-term outcome problems, and it has a short-term morbidity and mortality associated with it. If the serum creatinine has been tripled, it is stage 2, and it's more than triple, it's stage 4, stage 3, sorry. So don't go into the complexities of it. So I'll just make it a little simpler. So there are two ways the acute kidney injury can happen, whether it's a defect in the structure or defect in the function. If the modification that has happened in the structure leads to the physiological hypertrophy, it's fine, which happens usually in the single kidney, the kids born with the single kidneys. But if the structure has happened, like you have done a nephrectomy for some reason, or you have a scars in the kidney, or new scars developing into the kidneys, then the pathological changes occur. The same with the functions. So if the functions modifiers are usually the age and the high protein diet, liquid diets, and if the modifications are physiological, then it can be auto-regulated, filtration fractions can be managed, and if it is become pathological, then the acute kidney injury ensues. There is one more concept, that's the renal function reserve. This is the most important aspect to understand in the pathophysiology of acute kidney injury, that we all have a renal function reserve, and the creatinine, this is the glomerular filtration rate, this is the creatinine. So creatinine basically does not rise until you have a good renal function reserve. So once the good amount, approximately 50% of the renal mass has gone, till then your creatinine does not rise. So even if the small rise in the creatinine means a significant loss of renal function. These are the basically two markers. I am not talking about the biomarkers per se, because they are not in the clinical use as of now. These are the only two markers we have for the clinical use. The serum creatinine has its own pitfalls, as it varies with age, gender and the muscle mass. It rises only after the 50% of the function is lost. It has tubular secretions, so it overestimates the function and does not depict immediately. If you have acute kidney injury today, the creatinine may rise today, tomorrow or a day after that. And the methods of estimation, different methods have the different normal values for it, and it's been easy to dialyze. Once you dialyze the kid, there is no meaning of serum creatinine anymore. The urine output is important. It depends, its duration and episodes of oliguria has a prognostic value. It enables us early diagnosis. It improves management to act much before the serum creatinine has risen. But problem is that you cannot do it in ward, accurately at least. So basically it's used chiefly in ICUs. This is the another marker because we are trying to understand the acute kidney injury as early as we can, even before we met the criteria of stage 1 acute kidney injury. So this is the criteria we have made, the renal angina index. It's have the risk strata, injury strata, and we have a score for it. So if you look at the scores, there are only 3, 1, 3, 5, 1, 2, 3, 4, and then the 8. So the admission to the intensive care gives us a score of 1, solid organ or stem cell transplant 3, mechanical ventilation, vasoactive support or both is 5. So once a child is on ventilation, he has a high risk of acute kidney injuries. And look at the serum creatinine and a fluid accumulation in the percentage. So if you look at this, just the second stage, score 2, just 5 to 10% of the body weight gain, the fluid, extra fluid. 5% is nothing. If you look at the 10 kg child, the 5% means the 500 grams. 500 grams has a significant impact in the outcome. And this has been proven with the largest study we known as AWARE. It has been done throughout the world, including India. And this clearly shows that the person who are positive for renal angina has high likelihood of having a renal replacement therapy, longer duration of mechanical ventilation, longer duration of ICU stay, and the mortality. It clearly shows that person who are positive for renal angina, they are having a problems. So if we look at just the creatinine and the renal angina fulfillment, renal angina does much better than the creatinine alone in all these things, like renal replacement therapy, mechanical ventilation, and everything we have just talked about. So how is the epidemiology? So this is the old paper somewhere around 2006 when the rifle criteria came. So 7% of all hospitalized patients develop some kind of acute kidney injury, whether stage 1 or stage 3. If you look at the critically ill patients, is almost half of them will develop acute kidney injury, and 5 to 6% of ICU patients will require an RRT. And this is a huge number considering our population. That was an adult data, and this is the pediatric data, and this is no different. This has been published in 2015. Whatever definition you use, the percentage hardly changes. So it's vary between 35 to 50% as the definitions are used. What are the factors which affects the, which can make a child at risk of developing a kidney injury? If you look at this, sepsis is a major part. The drugs, these are the most underestimated part of acute kidney injury. Drugs are forming the major part of the acute kidney injury in an ICU setup. Then thrombotic angiopathy in adults, we can call it a preeclampsia, obstruction, some kind of cancers, shock. Cardiac surgery has a long part, acute decompensated heart failure. So basically the sepsis and the drugs. If you can control the infections and you can give the drug judiciously, then the incidence and prevalence and requirement of RRT can be delayed or avoided. So basically the emphasis is on early recognition. So the earlier we recognize, the earlier we act, the better are the outcomes. So any of the following will classify as the acute kidney injury. Increase in serum creatinine equal to or more than 0.3 milligram per deciliter over the last 2 days. Increase in the serum creatinine 1.5 times from the baseline from the earlier known value of that has presumed to occur within the last 7 days, or urine output 0.5 ml per kg per hour for the 6 hours. This was the earlier model of conceptual model of AKI basically. So we were trying to, if we look at the 2012 guidelines, they emphasize finding the AKI here in the damage part. But the current emphasis that who are as increased risk, if we can find it out, we can just avoid the decline in a GFR and just reduce the damage. So this is the most important part, that we need to find who is at increased risk of developing a kidney injury. So if you are diagnosing the kidney injury by rise of the creatinine or the oliguria, in fact anuria, I got the calls that patient is anuric. That's not the way I want to hear it. I want to hear it is that urine output is low, it's touching 1. You are giving a full maintenance fluid. He should be passing much more than 1 milligram per kg per day. So if it has started falling, it means it's something is going wrong somewhere. So the types and the consequences of kidney damage and dysfunction. If you look at the stressors, this leads to hyperfiltration. Then it becomes an insult, causes an FSGS, causes maladaptive repair, and this can lead to CKD. I am not talking about an ESRD, I am talking about a CKD. CKD means the child can develop a hypertension earlier, child can have a proteinuria, so they need a follow-up as well. This is an interesting figure that there are organ crosstalks. We all know that each organ talks to another organ. So if you have a cardiorenal syndrome that can cause an AKI, you have lung kidney, if you have a COVID pneumonia, you all have seen that those who have developed a kidney injury has a very, very poor outcome in COVID, hepatorenal syndrome, then sepsis. And all these things leads to AKI, and once the AKI sets in, it affects all of them again. So it's a vicious cycle that goes on. You have to break it. You just cannot sit down on it and think that I am controlling all these things and the things will get better. No, it will not, unless you support the kidney as well. Because kidney itself is causing the damage. It's a vicious cycle. You need to break it. If you look at the etiology over the past 30, 40, 50 years, earlier the infectious and diarrheas were more common. Diarrhea, ORS has saved us. So the HUS is going up and up. The infections are going up now. Glomerulonephritis has come down because of infections. Obstructions are becoming a major part, and CACOT is the main reason for having an ESRD in pediatrics age group. So if we look at the overall pictures, that what are the causes of AKI in pediatrics age group. So in developing world, basically it's a single disease like malaria, sepsis, leptospira, HUS, enzyme deficiency, and the obstetric complications in older age groups. But if you look at the developed nation, they are basically in ICU, older children with MOTS and sepsis. What are the risk factors that we can modify and we cannot modify? We need to understand it. So extremes of age, definitely we cannot modify. Gender we cannot modify. Pre-existing, any kind of illness we cannot modify. Once we have received the child, we can treat the sepsis early. Non-major cardiac surgery we can postpone. We can avoid radio contrast. We can avoid fluid overload. We can do judicious fluid restrictions, we can avoid nephrotoxic medications. All these things needs to be think that whatever I am pushing into the patient, is it really necessary? Look at these drugs. If you look at the statins and if you look at the PPIs and having an odds ratio of developing an interstitial nephritis is much more than NSAIDs. So PPIs are being written left, right, center. They are just giving, even as a newborn, sometimes I am seeing that they are being given PPIs and it's not good. It's not good. So PPIs, non-steroids, and then the other drugs. So what are the outcomes of AKI? How do we assess? So these are the 4 scenarios in which a AKI can develop. Basically, you can have a normal kidney with normal renal reserve, then the child can have a AKI, whether it's a subclinical AKI or a clinical AKI. Subclinical AKI can only be diagnosed with biomarkers, which is still not available with us. So we are currently diagnosing it here. But once we have a recovery or progression, it depends on the renal function reserves. There are ways to find out a renal function reserves, which we routinely not do. But once the child has the AKI, especially requiring an RRT, we should be looking at the renal functional reserve, that how much he has lost. So once there is an apparent recovery with the loss of renal function reserve, there is a chances that he can go into the acute kidney disease and then the CKD. Mortality is according to the stages we have. If you look at this mortality, this is I am talking about mortality, and this is a large data of 71,000 patients. Even at the risk level, it means the creatinine has risen just 1.5 times of the baseline and the urine output has fallen just for the 6 hours. The relative risk of having a mortality is almost 2.5 times. The child is bound for 2.5 times mortality is too much, and the injury is 4 times and the failure is almost 6.5 times. And this shows the basically the same things with the KDGO definitions applied, that no AKI has a better survival and the stage 3 AKI has a almost like 50% survival. This seems a little complicated, but we all need to understand that long-term survival is stratified by CKD and AKI. Even if you have a AKI, you may not develop a CKD or a AKD kind of things, but you will lose some kind of renal reserve, which will affect you, that if your kidney is bound to last for 100 years, they may last just 80 years. You may develop a hypertension if you are bound to develop it at 35, 40 years, and you may develop it at 25. What are the complications? If we look at the AKI complications, these are traditional complications which results from the direct loss of renal functions. They are basically corrected by renal replacement therapy like fluid overload, hyperkalemia, acidosis, and so on. The non-traditional complications, the things which I just talked about, like organ crosstalks, they are not corrected by RRT. They are only can be supported, like respiratory complication, inflammatory ARDS, cardiac dysfunction, liver injury, immune dysfunction, sepsis. So how do we evaluate? Once we diagnose the child has developed the AKI, so how do we evaluate? Basic evaluation. This is only the basic evaluation I am talking about. The blood counts, urea, creatinine, electrolytes. We need calcium. Sometimes I see the KFT report from a periphery which has just sodium, potassium, urea, creatinine, maybe a uric acid in it. We need calcium and phosphorus in it. We need bicarbonate. We need a blood pH. Urine analysis is the must. Without urine, you just cannot diagnose the cause of AKI. Urine has to be done, and it has to be done on a multiple occasions. It's not that yesterday we have done it, it did not show anything, so it means it's not showing anything. A sample may not have been collected because most of us are not doing it ourselves. Most of us do not have access of doing it ourselves. I do. So I do it once I think that something is wrong. I go down to the lab because I have an in-house lab. So I see it on the microscopy. But urine analysis gives you the more information than any other test. We need to have a chest X-ray for a cardiomegaly, pulmonary edema, and a ECG. Abdominal ultrasonography is must. Sometimes I see the patients being referred to me without an ultrasound. How do you know that reports you are seeing is an AKI or a CKD? If somebody has come with a creatinine of 2 with a normal urine, how would you know that it's a CKD or a AKI? Kidney size, kidney echo texture can give you an idea. It's not a shot, but it gives you an idea what we are dealing, how emergent it is. If you are pretty certain that what kind of the things you are dealing with, like you don't see GN in very young children, though HUS is much common in that age group. So if you are having a hematuria and little proteinuria with the kidney dysfunction, I would, in a 2-year-old kid, I would not think of a GN, I would think of a HUS first. So then do all these kind of investigation. GN, we need autoimmune markers. Biopsy, if not known cause is found or the patient is RPGN. This is another test. We all do it day in and day out, but we don't understand the value of it. So furosemide stress test, it has to be done in a 2-way. If the patient has never received a furosemide, it's 1 milligram per kg. And if he has received in the past 48 hours, then give 1.5 milligram per kg furosemide. If urine output is less than 200 ml, or we say in a pediatric age group less than 2 to 3 ml per kg per hour, it's a positive test. What does the positive test mean? Positive test predicts that AKI is going to progress. There is a need for RRT in a short term, and there is chances of mortality. We all do it and we just keep doing it every day. That's not an answer. That's not an answer. Once you have not got the response of furosemide, then the things gonna get worse. So if you have given a, just stop there. One dose good enough, proper dose, 1 milligram per kg or 1.5 milligram per kg, whichever you prefer. Look at the urine output, it's working, it's fine, it's not working. He needs an RRT. Urine analysis, I just told you, it's a pre-renal which is actually non-existent in today's scenario. Because once the creatinine has risen, it means it's renal. As simple as that. So pre-renal, you have to pick it early. Like you know that child has a diarrhea and has not passed urine in the last 6 hours. So it means that it's a kind of a pre-renal, but urea and creatinine are still normal. So that time you can decide whether it's a renal or pre-renal. ATN, you will not see anything, maybe reticuloendothelial cast. Infections, you will see WBCN cast. Nephrotic, we all know. Nephritic, the RBC cast and dysmorphic RBCs has to be looked into. Most of the urine reports do not mention the dysmorphic RBCs, so you have to specifically ask the pathologist to look for a dysmorphic RBCs by ordering the another test, the urine for dysmorphic RBCs. So they'll give you a percentage. Fluids in sepsis. Everybody thinks that push more fluids, don't do that. Avoid early undertreatment and late overload. Treat it very judiciously, early goal directed therapy, so that we can reach the map of 65, CVP of 18 to 16, venous saturation of 80%, urine output beyond 0.5 ml. There's no role of hexane starch in AKI, it even causes an AKI. Persistent overload leads to hypoxia and ARDS. So basically, you have to balance somewhere in between. How do you do that? The intensivists do that for us. Usually, we are not doing it. They do the lung ultrasound, they do the IVC measurement, they look at the right atrium filling pressures and all those things. They let us know that whether fluid is adequate in the body or not. Development of edema is too late. Development of edema means you are already 10-15% over. Prevent nephrotoxicity. Look at the aminoglycoside. I'll just tell you one case which we had in the last, I think, 3 months back. Drug levels. Why do we need a drug levels? Usually we see few newborns which are doing perfectly fine with early onset sepsis or a late onset sepsis, and we discharge them with amikacin injections for 7 days. Instead of 50 milligram, he was receiving 500 milligrams a day for next 7 days. And they took us into the court for that. What reason? The child should not have been discharged first of all, and the parent has not been told that aminoglycoside causes so much injury. This has just 3 months back. Luckily, I was not involved, but I was involved once that level shot up sky high. So we need to do BERA, we need to do everything. Luckily, nothing happened. So it's body. That's how we say. But always tell the parents when you are using an amikacin, especially in an OPD basis, it is going to harm. Amphotericin we avoid dose modification and renal failure. Every possible medication, whichever you see, except I think ceftriaxone and 1-2 more, will require a dose modification. Carry a book. There is a drugs.com site. You can always look into it. Loop diuretics, absolutely no role. Absolutely no role except the furosemide stress test. Do not improve survival. Do not cause the recovery. So if you look at the high doses, give it high doses on a daily basis, it will cause an autotoxicity rather than pushing at a AKI. There's no role of low dose dopamine, there's no role of phenyldopam as of now. So no pharmacological therapy either for the prevention or for the treatment of AKI. This is the most important part. Once a child has developed AKI, avoid restricting proteins because child may be in sepsis, in a catabolic state, he needs a protein. Intake has to be 20-30 calories, more than 30 calories per kg per day, kilocalories. So administer protein preferably by enteral route. The earlier you use the enteral route, the better it is, the earlier the recovery from AKI. It has been proven beyond doubt. So once the BP settles, we just start enteral feeds. This is the question the most of the people ask, when to start dialysis. The answer in pediatrics age group, I am talking about especially pediatrics age group, early. There is no data to suggest, there is adult data that suggests you can start it a little later and does not matter. But there is a clear data that starting early dialysis helps. Fluid overload, how do you calculate fluid? Whatever the fluid has gone in, whatever the fluid is come out, and the weight at admission. 50%, 80% mortality. If you are 15% overboard on a fluid, 80% mortality, straightforward. So basically, a patient with AKI who has developed edema and other complications, you have lost the cause. That is why most of the people think that last resort dialysis कर लो यार. लास्ट नहीं करना होता, पहले करना होता है. हम सांस रोकने का इंतजार नहीं करते ना वेंटिलेटर पे डालने के लिए. It's the same way. It's a kidney support. It's not a replacement. You have to support the system till it recovers. So indicators of delayed renal recovery is percentage of fluid overload, higher baseline creatinine, other comorbidities, use of vasopressors, which easily can be assessed by the renal angina index 3 days earlier before it happens. So early initiation of dialysis when there is a life-threatening fluid overload, electrolyte imbalances exist, and always consider a kidney support therapy rather than a renal replacement or kidney replacement therapy. It's a broad clinical what all can we modify with RRT? We can modify acidosis, we can modify hyperphosphatemia, we can modify, take out more fluid, we can manage it well. So intermittent or continuous, whatever you, once these complications developed, you are late. Dialysis has to be started much earlier than that. Whatever therapy you choose it wisely. Peritoneal dialysis is available everywhere, done correctly and the right time, achieved adequate clearances and water clearances, not very good in too much fluid overload. Hemodialysis is good. The problem is the jugular catheter. CRRT is absolutely wonderful in hemodynamic instability and organ dysfunction, sepsis. So the dictum here is peritoneal dialysis if isolated ARF, and because it's available, hemodialysis efficient, this is the one. Hemodynamically stable, intermittent therapies or peritoneal dialysis, good enough. Hemodynamically unstable, CRRT is the modality of choice, no doubt about it. So this is a start AKI, which I was saying this standard strategy is better or accelerating strategy is better. This is an adult data published 2 years back. It suggests that both are basically the equal. This is the pediatric data. we suggest that early dialysis and CRRT is much better than the standard therapies. Patients with AKI needs follow-up, they can have a full recovery, they can progress to CKD, they can progress to ESRD at the same time when the insult has happened. So everybody needs a follow-up after 3 months, and if you find that it's a CKD, it's a CKD then. So basically nobody should die of AKI, they can die with AKI, there is no problem with it. Mods can have a AKI along with it, but they should not die of AKI that for the need of dialysis. So recognize the patient at risk, this is the most important, maintain volume and perfusion, discontinue nephrotoxic agents, avoid radiocontrast, doses of the most medications will change, make sure that you are checking daily what medications are going on and what doses, limited role, effectively no role of pharmacological intervention, prompt renal replacement therapy, क्या कर रहे हैं, peritoneal कर रहे हैं, CRRT कर रहे हैं, intermittent hemodialysis does not matter, promptness matters, and they need prolonged follow-up. Basically, the take-home message is detect AKI early. The earlier you detect, the better the outcomes. Nephrotoxic agents prevents further, avoid nephrotoxic agents so that further injury can be prevented. Fluid overload predicts mortality. Avoid fluid overload, avoid fluid overload, avoid fluid overload. That is the one that kills. Associated with prolonged hospital stay and mortality. This is the ISN initiative that nobody in the world should die of AKI for the want of dialysis by 2025. They can die with AKI, but they should not die of AKI. Thank you.
It was a wonderful presentation, Dr. Amit sir. I now request Dr. Bhanu to greet Dr. Amit sir. I now request our honorable chief guest for the evening, Dr. Vikas Swarnkar sir, to kindly address the audience and share few thoughts with us. Dr. Vikas sir.
Thank you, Dr. Roop. I'll not take very long and keep you away from the rest of the program of the evening. A very warm welcome to our guest speakers from Delhi, Dr. Praveen Kumar, Pediatric Neurologist from Gangaram Hospital, and Dr. Amit Agrawal from Rainbow Children's Hospital, New Delhi. Wonderful talk, sir, and I'm sure the colleagues and fraternity members must have benefited from this enlightening lecture. We look forward to more of such events from you in future. I can see a lot of eminent faces in the audience from the specialty. Professor A.J. Mehta, sir, who is additional professor at additional principal at SMS Medical College, Jaipur, and Dr. B.K. Jain, Dr. Pathan Saab, who is the president of IAP, Dr. Sanjay Arya, a very close family friend, president of PHNHS, Dr. Tarun Patniji, Dr. Professor J.N. Sharma ji, Dr. Aneja, Dr. S.P. Sethi, Dr. H.S. Bhasin, Dr. Masant, Dr. Rajiv Jain, Dr. Kabra, Dr. Deependra Garg, and Dr. Chirag Sethi, who has come all the way from Alwar for this event, and our very own HOD Pediatrics, Mahatma Gandhi Medical College, Dr. Munish Kakkar, and the Department of Pediatrics and Neonatology at our hospital. I'm happy to share this is a very important event and moment for us as well, as we have already started our PICU unit and a 5-bedded pediatric nephrology unit. The idea of having a modern, equipped and fairly high capacity PICU took off when during the second wave of COVID, when number of pediatric patients were predicted to outnumber the adult patients. That is when we felt the need of having a proper big PICU. Until that time, we had around 7-bedded PICU. That was managed by the pediatric department, but not exclusively by pediatric intensivists and pediatric nephrologists. And God was kind. By God's grace, we met the team, our current team of pediatric intensivists and pediatric nephrology, Dr. Yashu, Saini, Dr. Roop, Sharma, Dr. Bhanu, and Dr. Ramesh Berwa. So right thing happened at the right time, and we immediately acted upon it and started working towards commissioning the unit. By God's grace and elders' blessings, we have now started our unit. It is equipped with one of the most advanced medical equipments, having close to 50 pediatric ventilators, dedicated USG machine for the PICU, and host of other essential infrastructure like video EEG for the neurocritical patients, and exclusively dedicated 5-bedded hemodialysis unit that is apart from the 70-bedded adult dialysis unit that is equipped with SLED CRRT, and also to provide CRRT to neonatal babies weighing more than 2.5 kgs. Expert and modern care comes with the commitment of ethics and fair practice. We are bound to practice ethical medicine and fair medicine, and this is what my guiding principle has been to my team throughout. We will treat all the children coming to us irrespective of their capacity to pay. उनके पास चिरंजीवी योजना है या फिर RGHS योजना है नहीं है, वो सब अलग है, but they will be treated irrespectively. Also, we have developed our unit to provide level 3 plus services, wherein we are already providing pediatric kidney, liver, and bone marrow transplant services. In association with Southeast Asia for thalassemia, we have done almost 15 bone marrow transplant for thalassemic children, and results have been at par with international standards. In continuation to this, to achieve academic excellence, being a medical institute, we are also planning to start in near future fellowship in pediatric nephrology, fellowship in pediatric critical care, followed by DM in pediatric nephrology and DM in pediatric care, critical care, once we have adequate and enough patient base to offer these DM programs. So with these words, I wish my team very best, all the best for future. I once again welcome you all for gracing this occasion, sparing time. I thank you all for this. Thank you very much.
Very encouraging words for our team. Thank you very much, Dr. Vikas sir, for these wonderful and encouraging words. Now I would like to ask and request Dr. Munish Kakkar sir, Professor and Head Pediatrics. Request Dr. Munish sir to greet Dr. AJ Mehta sir. AJ Mehta sir from SMS Medical College, Professor and Additional Principal. Before finishing off the program, now I would like and invite Dr. Yashu Saini to greet our listeners with vote of thanks.
Good evening, everyone. First of all, I would like to pay my regards from the bottom of the heart to our Honorable Chairperson, Dr. Vikas Swarnkar sir, whose constant and unconditional support has led us on this path, and we are moving forward for developing our unit to the best of the standards. I would also like to thank the esteemed faculty who has come all the way from the Delhi on a very short notice, of which I had opportunity to meet Dr. Praveen Kumar for the first time, but Dr. Amit has been my colleague during my fellowship days, and we had spent nights together managing transplant patients in AIMS. I thank both of them. Then I would like to pay my regards to the esteemed audience who are my seniors, my teachers, my colleagues and friends who had such a patience to listen the talk, which extended to about 1 to 1.5 hours. I thank a lot to all of them. And in the end, I would this would not be fair if I don't thank Dr. Manu Soni, who has given us unconditional support whenever I have opportunity to call him 24/7 regarding our issues, our hurdles which we are facing. And in the end, I would thank the entire marketing team, our IT team, for providing this support at very short notice. Thanks a lot. Now I would request the audience to proceed for the dinner. Thank you.